Good afternoon. I would like to welcome you all to this year's workshop of radiotherapy. It's talking about the brain SRS. And I would like to introduce the first talker, Dr. Ahmed Amin, the head of the radiotherapy department at the Bahia Foundation. He will be talking about the early treatment of Okay, it would be an intro for early breast detection. Thank you.
Good morning, everybody. Good morning, chairpersons. I'm really pleased and glad to introduce this this workshop for the year. First of all, I really want to thank you for joining the Bahia International Fifth Conference. On the side of the conference, we're having this workshop for, and when we thought about which topic to present for this year, we thought that the best thing actually to introduce is to talk about the treatment of brain metastases. I'm really delighted to present some of our colleagues and some significant speakers for today's year. Today we're having Dr. Khaled Abdelkarim, Professor of Clinical Oncology at Ain Shams University, one of the main team member of the Gamma Knife team in Egypt. I guess he's the most expert neuro-oncologist in Egypt, so it's really a pleasure that he's joining us today. It's also a great pleasure to introduce my colleagues from UK, from the Royal Marsden, Dr. Nicola Rosenfelder. She's the neuro-oncologist at the Royal Marsden. So we're going to have some really interesting talks for today. And again, I want to thank you again for joining us. And just because we're behind our scheduled time, we can proceed with our first talk.
Thank you, Dr. Ahmed. I would like to introduce Dr. Nicola Rosenfelder, the consultant of clinical oncology at the Royal Marsden Foundation in the UK. She'll be the first presenter. Welcome, Dr. Nicola. It's a pleasure to have you here with us. And the floor is all yours. Thank you.
Thank you very much. Right, so hopefully you can see that as a full screen.
Yes, it's working properly.
Yeah,
thank you.
Okay. So I'd like to start by thanking the course, congratulating the course organisers and thanking you for the very kind invitation, particularly to Dr. Amin Ahmed and my colleague at the Royal Marsden, Dr. Heather Solomon. And I'm really pleased that Martin Brewer, who is my neuro-oncology specialist radiographer superintendent colleague, is here with me so he can add anything that he sees fit. I'm also really sorry I can't be with you in person. I'd really hoped to be there in Cairo, but unfortunately couldn't make the timings work due to a prior commitment in London. But thank you very much again for the very kind invitation. So rather that we brought a little bit of Cairo of Egypt to England instead, but what I'd like to do is just tell you the overview of what I hope to spend the next 30 or so minutes talking about. So I'm going to start with a background of the evidence for stereotactic radiosurgery, or SRS, for brain metastases and also for tumour bed. In the UK, we work to the NHS England commissioning criteria, and I think for departments developing SRS units, I think the criteria actually are robust, and we've shown that they are very appropriate in terms of patient selection. So I'm going to spend a little bit of time talking about them and talking about our SRS service at the Royal Marsden. I'm going to present a few cases, and because this is a breast cancer conference, I've concentrated on breast cancer patients. We'll talk a little bit about the conundrum of follow-up scans and differentiating radionecrosis from progressive disease. I'll present our outcomes of our department and a few concluding remarks. So what's the evidence for SRS? Historically, whole brain radiotherapy was the standard of care, but in 2004, this seminal paper, which was a randomized controlled trial by Andrews et al., was published in The Lancet. And they recruited 333 patients from 55 centres, and they compared whole brain, the standard of care, with whole brain plus SRS. And what they showed is, I don't know if you can see my mouse, but in the top left-hand graph, there was no significant difference in overall survival in all patients. So these are patients with 1 to 3 metastases. But you can see the median survival was pretty poor for both groups. It was around 6 months, plus or minus a month. But when they looked at the patients with a solitary metastasis, there was a significant benefit to the addition of SRS over whole brain. And this benefit was also shown in the patients in the best prognostic groups. At that time, we used the recursive partitioning analysis for dividing patients into better or worse prognostic groups. And those in the best prognostic group also had a significant survival advantage. And the other thing that was shown in this study was that all patients, regardless of whether they had 1 MET or 3 METs, had either stability or improvement of their Karnofsky performance status that was significantly better when SRS was added to whole brain. And we often have this thing of mission creep in radiotherapy, that if something's shown in one group of people, we sort of extend it out to another. And so even though this study showed that the addition of SRS was really only suitable in patients with in the best prognostic group or 1 MET, people began to do it much more in all patients with a limited number of metastases. We then looked at, this paper was another seminal randomized control trial published a couple of years later in 2006, where SRS was a sort of taken to be the standard of care, and then whole brain radiotherapy was added into it. And in this study, you can see on the graph on the left, there is no survival benefit to the addition of whole brain radiotherapy over SRS. So the p-value is 0.42 and the curves are pretty similar. So there's no survival benefit to whole brain radiotherapy, but actually on the curve on the right, you can see there is an improvement in distant recurrence if people give whole brain radiotherapy. But anyone who's given whole brain radiotherapy knows that this potentially comes at a significant cost in terms of side effects. So the advantages in preventing, it was local and distal recurrence, but there was no survival advantage. So at this time, I think many centres stopped using whole brain radiotherapy in patients with, this was 1 to 4 metastases. So the next seminal paper, I'd say, was this was another randomized control trial published in 2009, where again, SRS was compared with SRS and whole brain. And this study actually closed after only 58 patients were recruited, because the data monitoring committee saw very, very early that the 4-month deterioration in learning and memory was significantly worse with a whole brain radiotherapy versus SRS alone. And you can see there's a delay in total recall, delayed recall, and delayed recognition. So even though we know that whole brain radiotherapy reduces the chance of distal disease coming, this is proven that it's a significant cost of neurocognitive function. I'm not sure there are any centres anymore who would routinely give whole brain radiotherapy with SRS, but certainly we stopped doing it many years ago. So all of these studies were done with patients with up to 4 metastases, but why is that a magic number? And this paper, published by a Japanese group in 2014, again, that mission creep I was talking about, we've got data for up to 4 metastases, but obviously people were treating patients with many more than 4 brain mets. And this was a really helpful paper. This was over 1,000 patients treated in a number of centres in Japan. And the authors compared the outcomes in patients with 1 metastasis, which is the green curve, versus 2 to 4 metastases, which is a blue curve, and 5 to 10 metastases, which is the red curve. And you can clearly see a difference between the green curve and the other two. And there's a statistically significant improvement in overall survival of the patients with 1 tumour versus more than 1 tumour. But there's absolutely no difference between 2 to 4 or 5 to 10 metastases in terms of the outcome, with a p-value of 0.78. So on the basis of this, we can say that radiosurgery alone is non-inferior for 5 to 10 mets compared to 2 to 4 mets. And interestingly, if we look at the breast group, because the authors had a lot of patients, so they could look at tumour-specific outcomes. And actually, there wasn't even a difference between the 1 met versus 2 to 4 mets as shown here. So in breast cancer patients, we know the survival is probably similar, depending, it doesn't really matter how many metastases one has. What about the dose? This is a retrospective study which clearly shows that dose matters. The survival function in terms of local relapse was considerably better with 24 Gray versus 15 Gray or 18 Gray. So we would not usually recommend a dose of less than 18 gray unless it's in a single fraction. That would be the minimum that we would normally recommend treatment with, unless it's in a very radiosensitive site like the brainstem. But certainly our standard doses are 21 gray in one fraction for breast or lung cancers, and we escalate the dose in more radio-resistant cancers like melanoma or renal cell cancer to 24 gray in one fraction. And of course, we will fractionate if needed. And the reason is because of this. As one increases the dose, I don't know if there are non-radiation oncologists in the audience, but this V12 is the volume of brain receiving 12 gray. So we take the whole brain and we subtract out the tumours, which are the targets, and we look at the dose that the rest of the brain receives. And as the volume of brain receiving 12 gray, which is a cutoff, goes up, we can see the chance of causing radionecrosis goes up. We use a cutoff of V12 of 10 cc, so we don't really usually accept a plan if more than 10 cc of normal brain is receiving 12 gray. This has shown subsequently to be a very conservative estimate. The true likelihood of radionecrosis is probably quite a lot lower than this, and certainly we do not see 24% of patients having symptomatic radionecrosis. It is probably less than 5% of patients. But the V12 is important, and dose escalation, whilst it's good for the tumour, is not good for the surrounding brain. Post-operative SRS is somewhat contentious in the UK because of what we're allowed to deliver or not. But there is good evidence, again, from a randomised trial where patients were randomised to observation or SRS following complete resection of 1 to 3 brain metastases. And you can see here there's a clear benefit to post-operative SRS in terms of freedom from recurrence at the operated site. That's very clear, I think. And the hazard ratio is actually 0.46. So you can, the risk reduction is by 54%, which is pretty significant. But the problem is that there was no difference in overall survival. So one can reduce local recurrence-free survival, but that didn't seem to impact in this study the overall survival. And because of that, our commissioners say that we should not be routinely offering post-operative radiosurgery to patients with completely resected brain metastases. However, if our surgeons are worried that there is residual disease left behind in the cavity, or if and the MDT agrees that it's reasonable to proceed with post-operative radiosurgery, then we can give it. And this will always be fractionated radiosurgery. So we tend to give 3 fractions on consecutive days because the cavities tend to be too big for single fraction radiosurgery. This is another randomized study comparing post-operative radiosurgery with post-operative whole brain radiotherapy. I don't think these curves could overlap anymore, really. The hazard ratio is nearly 1. So there's certainly no difference in overall survival between post-op SRS and whole brain. And we just shown before there's no survival to SRS versus observation. And once again, this study confirmed what we've already shown from the previous study, that whole brain compared with SRS is much more likely to cause cognitive deterioration. So I'm not sure if there's anywhere that would give whole brain radiotherapy after surgery. So I've already mentioned some of the NHS England commissioning criteria. One can see their policy online. And essentially there are 8 criteria which our patients need to fulfill for them to be eligible for radiosurgery. And like I said at the beginning, I think that they are useful, they are good criteria. The first one is that the patient should be deemed suitable for radiosurgery by their local MDT. So if it's a patient with breast cancer, it would be the breast MDT, lung cancer, lung, etc. But they also need to come through our specialist SRS MDT, which is core with neuroradiologists, neurosurgeons, neuro-oncology specialists, radiation oncologists, and specialist nurses, and obviously radiographers. And they have to be deemed suitable at that MDT. And at that point, we say they've been accepted for radiosurgery. They have to have a KPS or colonoscopy performance status of at least 70. And I would say this is the single most important, this is probably the single most important prognostic factor for outcomes. They have to have an established diagnosis of cancer, absent, controlled or controllable primary disease. So this is probably more relevant for patients, for example, with melanoma, but then we do sometimes have referred to us patients who have run out of all standard treatment systemic therapy options and don't have any trial options available to them. And if they've got uncontrolled disease in their brain, even if they fulfill all the other criteria, they are not suitable for radiosurgery because they don't have controllable extracranial disease. Number 6 is quite obvious, that if they have pressure symptoms from something that needs surgery, they shouldn't have radiosurgery. And they have to have a total parenchymal volume of up to 20 cc. So it's a volume constraint, not a number constraint. So we do treat, again, going back to that mission creep, we do treat many people with more than 10 brain metastases, and I'll show you some data later. But the volume and distribution needs to be favourable. So sometimes we might see someone with, say, 30 metastases, and we'll say we can treat them. At other times, we'll say other patients we may not be able to. The other thing is they're meant to have an expected life expectancy from their extracranial disease of more than 6 months. And I'll show you data that we are not very good, I think, as a community of oncologists. We're not very good at judging that sometimes, but that's the criteria. This is our pathway. So again, for anyone developing an SRS service, the date that they're discussed at the MDT is the date that we accept them for radiosurgery. And according to our commissioning criteria, we then have to see them within 7 days of acceptance. So we see them in clinic in the following week, because that 7 days includes Saturday and Sunday. At that clinic, we consent them for radiosurgery, do a steroid prescription, and then they come for thermoplastic mask fabrication, planning CT in the mask, and a volumetric MRI not in the mask. And this whole pathway, you'll see all the number of steps. This takes an immense amount of coordination. And Martin's role is absolutely crucial to the service working. He coordinates so much for these patients, even before they come to clinic, because all of this needs to be done from the clinic review until treatment has to be done within 14 days. So we have to have a mask, CT and MRI, that's done in 1 day. That has to be fused. Then we contour the targets. We need to get the formal report of the MRI and then check our contours against that and sign off the checklist to say we're happy for that to proceed to planning. The physicists then create a plan, then we have to review the plan, sign it off and prescribe it, and then the physicists do their final checking in QA, and then it's treatment. And all of that has to be within 2 weeks. The other thing that Martin does, which is also crucial, which is time the treatment with respect to the patient's systemic therapy. So for many patients, particularly patients on things like Kadcyla, we do not want the radiosurgery to be close to the systemic treatment. So we'll give the radiosurgery just before the next cycle is due. And again, that's crucial to have a multidisciplinary team working together to make this happen, because I can tell you when Martin's away, sometimes it is very difficult. Following treatment, patients are reviewed again by the specialist neuroradiographer, and then discharged back to their primary team for ongoing follow-up. And we ask them to do 3 monthly MRIs after treatment. These are our dose constraints for planning. I'm happy to share them if anyone wants afterwards. But like I said here, this is the normal brain. So this is normal brain minus our targets, and we aim for, we're actually a bit more generous in this. We aim for V12 less than 10 cc. But around any singular metastasis, we want the volume of brain receiving 12 Gray, so in a local area of less than 5 cc. And for fractionated treatment, we use 19.5 instead of V10 or V12. Ideally, we want V10, but actually we accept V12. What about further radiosurgery? Well, we are able to give further SRS to a new lesion if at least 3 months has passed from the previous SRS. And I think this is entirely reasonable, actually, because we've seen patients who have, developing new metastases quite quickly after previous SRS. If it's within 3 months, I think that is usually indicative of a sort of a state that's out of control, in that we probably won't ever catch up with the disease. I'm going to present some patients who did have disease at 3 months, which may be worrying, but then had very good control after. So I think 3 months is reasonable. And we can re-irradiate the same lesion as long as 6 months has passed. And again, I think that is reasonable, because further growth within that time does suggest a radio resistance. So I'd just like to discuss I'm going to show you three cases for this talk. The first one is a patient who had invasive lobular cancer, which was ER positive, HER2 negative. And essentially, she had her original disease diagnosed in 2008 and had a number of loco-regional relapses, which were treated with further localized disease and then systemic therapy. But then in 2018, she developed symptomatic brain metastases. She had 5 metastases, and this was the biggest one in the right temporal lobe, which I've shown here. We treated all of them with radiosurgery, and because of the size of this one, we gave fractionated treatment to all of them. And this is the planning MRI, again, for the non-radiation oncologists. This is we design the treatment based on the MRI and fuse that with the CT, and the CT is needed to calculate the dose. But you can see the eyes have been contoured, the optic nerves have been contoured, the brainstem, and here's the tumor. And so we contour the tumor itself as the GTV, and we treat with a CyberKnife machine, and we don't apply any margin to the GTV. This is the treatment margin. And the tumor is prescribed to the 98% isodose. So it's 24 gray in 3 fractions. Sorry, to 98% of the volume. So often we try to aim to prescribe to somewhere as low as a 50% isodose, so that you can get a very hot spot in the middle of the tumor up to 48 gray. But usually it's somewhere between the 50 and 60% isodose. So within the tumor, it gets more than 24 and 3. So at the edge, it will get somewhere like 24 gray and 3 fractions, and then the dose falls off very quickly in the brain outside. Just to show to anyone who may be a doubt as to whether radiosurgery works, this was the tumour in March 2018 before treatment. By just 3 months later, you can see just a sliver here of enhancement. And by September, it had gone all together. And you can see, hopefully you can appreciate, there's some edema around the lesion, which had gone already by June, which would have mean she could have come off the steroids without any problem. The next case is a patient who presented with some left arm weakness. And she was found to have 8 lesions. One of them was in the right precentral cortex in the motor strip, which accounted for the left arm symptoms. I haven't shown that slice here, but I've shown some of the other metastases throughout the brain. And she had, again, 3 fractions, just because we wanted to go a bit more gently to that very the sensitive motor strip, which we're worried we did not want to cause any radionecrosis there. So this is her couple of slices showing what the tumours looked like at the time of planning. And you can see, again, just 3 months later, she had a very good response in all of these lesions. This is that right motor cortex metastasis. It doesn't look that different, and there is some edema. So the reason I wanted to show this is just that sometimes we've seen patients who have developed seizures following radiosurgery because of edema. And so sometimes with these patients, we want to wean the steroids a bit more slowly after radiosurgery. But generally, she'd had a very good response. This hadn't grown. If anything, it was a bit smaller. But unfortunately, at that 3-month April scan, we saw 3 tiny new micrometastases, as I've shown 2 of them here. There's one in the cerebellum. And I think it'd be reasonable to start being a bit anxious to think that it's only 3 months and she's already developed new disease, because we'd have done a volumetric MRI with a planning scan beforehand. And you might want to be a bit cautious in the advice you give to the patient. But we treated these areas with further radiosurgery. And that was in April 2021. And you can see that now in September 2022, she remains fit and well, and it's just been re-referred back to our service with this very small area in the right frontal lobe. But what's interesting is you can see this has gone completely. There's no edema, and all the other sites have remained extremely well controlled. So one doesn't need to be too anxious about people who develop small volume new disease quite early on, because often that might just be something that's declared itself, soon after the first one, but then that might be it. So she's done extremely well, remains, fit and well, and is having further radiosurgery, has just had further radiosurgery with us. The third and final case I want to present in this section It's a patient who had ER-negative HER2 positive disease, or has ER-negative HER2 positive disease. And she's been on Phesgo, so a combination of pertuzumab and trastuzumab, for quite a long time. And unfortunately, she developed some neurological symptoms in August 2020 and was found to have extensive brain metastases with quite extensive edema, as you can see here. And this patient was clearly not going to be a candidate for SRS. And so she had whole brain radiotherapy and had 20 Gray 5 fractions. And the reason I wanted to show this case is really to say that whilst we've moved very much away from whole brain, there is still very much a use for it. And there are patients who do extremely well. And when we are referred some patients who are borderline, we might say, look, whole brain now, but please keep us updated and refer back to us if we can consider, if they respond well, and we can consider boosting them. This patient responded extremely well, and you can see 3 months after whole brain, she's had an amazing response in all treated, in the whole brain. And she was followed up with serial MRIs. But in October of 2021, so just about a year ago, she was found to have that some of these small residual areas were beginning to grow or re-emerge. So she was referred to us for radiosurgery, and we treated 15 sites. Now, in the original study of SRS versus SRS in whole brain, which I presented earlier, they did drop the dose of the SRS in the patients who were having whole brain. They dropped it by 30%. But we don't do that, and we are happy to, deliver the full dose to patients, even if they've had whole brain before. We don't see an enormous number of patients coming with radionecrosis. I elected to treat this patient with 20 Gray 1 fraction just because she was having 15 sites treated, so I didn't want the V12 to be too high, but probably could have gone to 21 Gray 1 fraction. And this was a year ago, and she's done extremely well. She's still KPS 100. She's still on Phesgo, still very good. And only recently there's been some hint that things may be re-emerging in a few sites, and we may give her some further radiosurgery. And there's one site which may be new. Now, one of the things that we find is that sometimes it's quite difficult to say, was this a site that we treated previously, especially when we're treating 10, 20, 30 plus METs in one patient. To say on a follow-up scan, is this a new site? So what our very patient and kind physicists and radiographers do is they will import an MRI scan into the planning system, and they will put on the superimpose of previous targets that we've treated. So we can see this tiny new metastasis here, which is right next to one that was treated, but this is an untreated area. So she will have further radiosurgery to that. Just moving on now to talk briefly about the difficulty sometimes in determining whether something's on post-treatment, whether any changes are due to radiation necrosis or radiation-related change versus tumor recurrence. So this is a patient who her metastatic disease came to light when she presented with neurological symptoms, and she underwent resection of a solitary left cerebellum metastasis in March 2018, and we followed that with some radiosurgery. Like I said, radiosurgery to tumour beds are always fractionated because of the size, and she had 24 Gray and 3 fractions and did extremely well. This was her scan 9 months later in January 2019, and I think you can see it's pristine. But about 9 months after that, unfortunately, her scan changed, and you can see some increased contrast enhancement around the tumour cavity with some associated edema. And I think even the best neuroradiologist in the world sometimes has to say, look, we don't know whether this is tumour recurrence or whether this is radiation-related change. And sometimes what we do is we just follow these patients up quite closely with serial MRIs. But we also have available to us an MRI software package for something called contrast clearance analysis, or TRAM scans, which essentially is when we take a scan at 60 minutes after the contrast, and we subtract the 5-minute and 60-minute scans from each other. So we can see what's happening to the contrast over that hour. And we get a map, and we'll show you some of these later on. But essentially, the map tells us if there's lots of contrast hanging around at an hour, then it's likely that this contrast enhancement represents tumor damage, vascular damage from the radiation. But if the contrast rapidly washes in and rapidly washes out, then it's likely to be tumor recurrence. And so we do sometimes use these CCA maps to help. But this patient had radiation necrosis. This is another patient. We have a similar problem where it was a patient who was treated with gamma knife in Leeds, so in Northern England, to 2 areas. She had breast cancer and was referred to the Marsden for consideration of a clinical trial. And her tumours were very well controlled following the gamma knife. But when she had the screening MRI for entry into the trial, both of those areas looked bigger, with more edema, and on the basis of that, she was excluded from the trial. But her scans came to us in our MDT, and our neuroradiologist said, hang on, this may well be radionecrosis. We did one of these CCA scans, and that was concordant with it being radionecrosis. And in the end, they were right, because she went into the trial, she did extremely well, but at some point, each one of these lesions enlarged further, and she underwent surgery, and there was no tumour there. So it's just a word of some of the things that we struggle with in our MDTs following radiosurgery is about whether the changes are due to radionecrosis or due to tumour recurrence. So I want to thank Martin for he puts together all of our outcome data and presents them every quarter to us to see how our patients are doing. So he's made most of these graphs. But essentially, when starting an SRS service, I think, you can see that the service at the Marsden started in 2016. You can see there's just been a kind of relentless increase in the number of referrals. There's a slight dip here that was due to the pandemic. And, the majority of patients have brain metastases. The patients referred for benign tumours are relatively stable. The number of patients the biggest group of our patients are patients with lung cancer, but the breast group is creeping up and is nearly at 30%, and they're certainly consistently our second biggest group. When we are referred patients, they usually come with a diagnostic scan, which may or may not be a volumetric scan, but when we do the radiosurgery planning, we take images every millimetre through the brain, and we often pick up additional sites of disease. So in nearly 50% of patients, we will see additional sites, and some of them will see more than 10 sites, and these are the ones that we still deem to be appropriate for radiosurgery. So again, just something to bear in mind in terms of planning the capacity on the treatment machine, that our neuroradiographers are very good at finding additional capacity, but sometimes it's just not possible if we've just got lots and lots of patients coming with many more mets than we'd originally thought. Overall, the biggest group of patients are those with 1 tumour treated, 2 to 4 a close second, 5 to 9, but we are treating coming up to 20% of patients with 10 or more brain metastases. The majority of our patients get a single fraction, but quite a few now have fractionated treatment. We give 5 fractions to things that are very close to the optic nerve, but that's very uncommon for us to do that. And you can see that of the fractionated treatments, the majority are given as fractionated treatment because of the size of the tumour rather than them being tumour bed. This just shows the tumour volume per patient, and most patients have a tumour volume of 0 to 4 cc, but obviously we're not meant to be treating patients with volumes more than 20 cc, but occasionally we do if it seems very appropriate. For example, if it's just over 20 cc, a tumour bed once you've added the margin. What's been really noticeable over the past year or so is the number of patients coming back for further SRS, and that's a very encouraging sign that our patients are living longer. The extracranial disease is better controlled, and also their intracranial disease is better controlled. And breast and melanoma patients are the 2 groups who have the largest proportions of patients coming back for reirradiation. We've got some patients who've come back 4 or 5 times for reirradiation, and I think that's a really encouraging sign. Our outcomes. At the beginning, I was saying about we meant to only treat patients with an expected prognosis of more than 6 months. And like I said, we're not very good as a community at predicting that, because about a quarter of our patients don't live for 6 months. But that is not different from all the published data in terms of survivals post-SRS. We see a similar this is what it looks like. So there's often this steep fall off to the first 6 months. The shape of our curve, I think, is not very different from anyone else's. Our median survival is 12.5 months, which I think is about right, because I think if it was a lot longer, it would probably suggest that we're not treating enough patients, we're missing some patients. And if it was a lot shorter, then we're probably over-treating some patients. Just a few comments about what are the important factors in terms of outcome. Like I said before, our patients have to have a KPS of 70 or more. And it's clear to us that the patients who come back repeatedly are those who are KPS 100 or possibly 90, and they have a significant improvement in survival compared, and a much sort of flatter curve compared with those with lower KPS, particularly KPS 70. Again, looking at the extracranial disease, those with no extracranial disease do a lot better than the new diagnoses or those with controllable extracranial disease. I think a lot of the new diagnoses are driven by the lung cancer patients because they're screened more for brain metastases. And we know that the patients who have synchronous brain metastases from lung cancer are a much poorer group in terms of their outcome. The volume is important. So, like I say, NHS England criteria is about volume rather than number. And you can see that the volume 0 to 4, which is our biggest group of patients, do significantly better than 4 to 12 or 12 plus. Number is also important, but again, similar differences between 1 and more than 1. But what's interesting here is you can see the median survival of our patients with 10 or more metastases is definitely not worse. So an extension of the IOMA paper that I presented earlier, 10 mets, again with that mission creep, I think our practice of irradiating more than 10 mets as long as they're within the 20 cc is the right thing to do. In terms of the survival by tumour type, you can see again breast and melanoma stick out as being particularly good. And again, the other thing to notice is the mean compared to the median is a lot higher, which is indicative of that sort of tail of the curve. So once patients survive, to the median survival, they've got a good chance of surviving quite a long time after. We looked at the effects of driver mutations, and unsurprisingly, patients with HER2 positive breast cancer do significantly better than with those without the mutation, just probably a reflection of the additional systemic treatments available to them. And that's similar to the effects of EGFR ALK mutations in lung cancer and BRAF in melanoma. This is at a more granular level, so it doesn't matter if they're ER or PR positive, probably not very much if they're HER2 positive, but it does matter if they are, there's a bit of a difference between triple negative and ER positive, HER2 negative in terms of our outcomes, again, statistically significantly different. And sorry, just before I move on, there's one other thing, which is that with more targeted, with better systemic therapies, particularly for the HER2 targeted agents that penetrate the brain, we're now seeing patients coming through with options for systemic treatment that can maybe treat the brain metastases. And we're beginning, some of our medical oncology colleagues prefer to try those drug treatments before coming to us for radiosurgery. And just like with lung cancers, with EGFR or patients, for example, who might start osimertinib, the question is how to sequence radiosurgery with these systemic therapies. In lung cancer, we don't know, and it's going to be difficult to get the answer because these are such relatively rare mutations. But with breast cancer, I hope we will be able to do some good studies to understand how to sequence radiosurgery with the HER2 targeted systemic therapies that have much better brain penetration. So in summary, with our service, we have increasing patient numbers, and that's probably because of some coming back with increasing survival and more access, more liberal use of MRI scans. SRS treatments have a very complicated pathway, and you need a really good multidisciplinary team working very closely together. We see excellent responses, but I think there's only a role to do SRS if you're going to continue to actively go out and look for further brain metastases in these patients, because we see they can come back quite quickly. And the whole point of SRS is basically avoidance of whole brain radiotherapy. So we need to pick them up early when they're not causing side effects. It can be difficult to distinguish post-SRS change, the radionecrosis versus progressive disease, but we can retreat patients, either new lesions or previously treated areas. And we know now there's increasing use of systemic therapies for breast cancer, which are brain penetrants. We need trials to know best how to sequence these with SRS. So again, with this multidisciplinary team, I'd like to thank and acknowledge my wonderful colleagues, Martin, like I said, who looks at all our outcome data every few months, and my other consultant colleagues, the physicists, neuroradiologists, and all the radiographers, and of course all the patients and their families. Thank you.
Thanks a lot, Dr. Rosenfelder, for this very detailed presentation. We may have a couple of questions before moving to the next presentation. Any question from the floor?
Thanks, Dr. Nicola, for your presentation. I want to know what is the limitation of SRS. I saw a case you give treatment for 15 lesions. Is it the volume of the brain, or is it the number of lesions? And what about the toxicity for this irradiation to this large number of lesions? Thank you.
Yeah, thank you. So it's certainly not, well, it is both volume and number. Volume, we're very comfortable treating up to 20 cc of disease in total. So for a single metastasis, something usually with a diameter of more than 3.5 to 4 centimeters will not be suitable for SRS, because we cannot meet the dose constraints. But with a total, if there are lots of multiple metastases, up to a total of 20 cc is acceptable. We have treated patients with 30 plus small metastases, and we know from our data that patients with more than 10 metastases do just as well as those with 2 to 5. So we're very comfortable treating them. It's a long treatment though, so they have to be fit to lie on the couch for up to 5+ hours sometimes, but often our patients have 2 or 3 hour treatments, and quite a lot have over 20 metastases. In terms of the toxicity, we don't see very much. We're very careful about accepting plans where the volume of the normal brain receiving 12 gray is low. And the main side effect really that we see is tiredness, which usually wears off after a few days. And we treat patients with steroids. So unless we're treating only a very few small micromets, we will almost always give steroids for the days of the radiosurgery and to wean after if they're not already on steroids. But if they are already on steroids, then we'll wean them much more slowly. And similarly, if we're worried about, for example, something in the motor strip, we will again be much more cautious about not weaning the steroids too quickly. So we're comfortable treating many metastases, and the toxicities really are not, we don't see significant toxicities. I mean, Martin sees the patients after treatment and probably can comment about what he sees, but certainly from when we see them coming back to clinic, they don't seem to have significant problems. Martin, I don't know if you want to add anything. Oh, you're muted.
Sorry, yeah, I would agree. It tends to be the patients that may get the most toxicities are those which already have symptoms and probably not so good in terms of performance status, but yeah, generally fatigue. Occasionally some may have some occasional headaches, maybe a slight worsening in any symptoms that they already had, maybe like sort of weakness in the arm or something like that. But yeah, generally everyone does quite well.
I think the use of steroids needs to be very careful as well, and that's part of one of the things I sort of glossed over that we do in clinic. But we spend quite a lot of time, looking to see have patients got significant edema, and where is the tumour? Because if it's in a more radiosensitive part of the brain, we will worry more about the toxicity.
Thank you, Dr. Nicola. I have collected the remainder of the questions from the audience. The first one is, do you have a fractionation preference in cases that need fractionation doses?
Yeah, so when I started, I kind of always used to do a sort of BED quick back of the envelope calculation and thought, oh, 18 and 1 is better than 24 and 3. Actually, I'm not so sure anymore, and I think my colleague would agree with that. We often discuss it. So essentially, for the more radiosensitive tumours like breast and lung, we try to give 21 in 1. We will drop that to 20 in 1. So if it's in the motor strip, or if it's in some, one of the basal ganglia or thalamus, around there, we'd often give 20 in 1. If it's in the brainstem, we'd give 16 to 18 in 1. If we need to fractionate it because it's too big to be able to give 20 in 1, then we would give, usually you would try 24 in 3, but if we can't meet the V19.5 of a local V19.5 of less than 5 cc, or a global V19.5 of less than 10 cc, then we could drop that to 21 in 1. And some of the cases we're going to show later, we have done that. So we try for single fraction just because of resources and because it's easier on the patient and fewer days of steroids. But if we're worried at all, we'll easily switch to 3 fractions.
Okay, the second question, for fractionated courses, do you give them daily or every other day, or if there's another
consecutive days? But if we have to, because of timetabling, we can go over the weekend. So it might be Thursday, Friday, Monday, for example, but we just have to extend the steroids for a couple of days because of that.
Okay, thank you. The third question, how do you confirm complete resection after a post-operative case?
That's a very good question. So we're very fortunate to work with excellent surgeons, and they are meticulous, but we know that even with their excellent skills, that there is a risk, particularly of leptomeningeal disease, and the posterior fossa resections especially seem to be prone to recurrence with leptomeningeal dissemination. We simply just do a post-operative scan, and occasionally we do see nodules even on that scan. We know from, I think it was an Australian paper which showed that the longer you wait, probably there's a detriment in terms of the outcome. So we do try and usually see patients about 2 weeks after their resection, so when the path is back, and then we treat them within 2 weeks from that. So they usually they come out of hospital after a day or two, and by the time we do a scan, it's about 4 weeks. We still aim for 24 and 3 for all patients, but we'll be more insistent on that, or we'll try to get that if there's any more suggestion of nodular disease. But I guess what's behind the question is it is often very difficult to differentiate post-surgical change from recurrence. But if there's nodules there, we're highly suspicious of surgical change, of recurrence.
For the last question, if a patient is presenting initially with brain mets, do you give SRS or do you wait for the control of the primary disease?
No. If they meet the eligibility criteria, so they're suitable for systemic therapy, they're good performance status. So we want their primary oncologist to confirm that they are a candidate for SRS, i.e. that they're going to treat their extracranial disease, but we'll treat them up front. So normally there's a sort of impetus to start the systemic therapy, and we interweave by the time we've done the planning and everything and have seen them, we'll interweave the radiosurgery and give treatment just before the next cycle of their systemic therapy is due.
That was very helpful, thank you.
I just have another question, please. First of all, I would like to thank you very much for sharing your experience and your cases. From your experience about the retreatment or re-irradiation, do you believe there is a window for re-irradiation that you have to wait for a certain time before considering it's a safe treatment? And have you ever tried to do 2 re-irradiations or a second re-irradiation, or just it's too much for such high doses?
Yeah, very good question, and hopefully we will answer that in our. So Carol Meehan is one of our physicists who's just joined as well. We will be addressing those in the planning section. But in answer to the first question, according to our commissioning criteria set by NHS England, we have to wait 6 months. And I think that's reasonable because a recurrence within that time suggests that the tumour may be radio-resistant. But after 6 months, we're very comfortable at re-irradiating an area. We do counsel the patient that there's probably an increase, well, there will, almost certainly will be an increased risk of radiation necrosis. We're going to be looking at all of this in the study that we're running at the moment at the Marsden in terms of the outcomes and the dose response, etc. But certainly from the retrospective data that's there, there's an increased risk of radiation necrosis with re-irradiation. So we might be a bit more cautious in our dose constraints that we accept or that we aim for. We may sometimes will elect to fractionate the treatment. In terms of a third irradiation, we have done it. We do it with trepidation and caution, and we have to. We say that we want really good evidence that there is further tumour. Again, because of that conundrum about differentiating radiation necrosis from tumour recurrence. Carol, Martin, and I will present a case where we have irradiated an area 3 times, but often we'll watch and wait changes on a scan to make sure they've declared themselves as recurrence rather than necrosis. But we will use those CCA scanning technique that I mentioned, if possible, if it can help.
Okay. Lastly, I believe my colleague and friend, Dr. Marwan from Canada, he's just joined us, and he has a couple of questions. He's also working in the neuro-oncology department at the Dalhousie University. So, Marwan, can you join us for a question, please?
Yes. Thank you, Dr. Rosenfelder, for this terrific presentation to take us through the state-of-art practice in UK. So I'm SRS specialist here in Canada. So I agree with you. We do the same practice. However, we have a few differences. Like we have the CEC 7 protocol that fractionate versus SRS after the surgical resection. We use the Manatee fractionation 27M3 or 30M5. Sometimes we are unable to achieve the 12 to limit it to 10 cc. Our protocol allows for more. We can go up to 30 cc actually, and it's on the trial protocol. So I have a question for you. For the brain necrosis, what's your approach in patients with brain necrosis? You know that this is one of the most difficult situations we face in our practice. So do you have any comment on using pentoxifylline with vitamin E in some like very scarce literature on this? I know that we refer patients for surgery, we use steroids. I recently met a case, they asked about this, and also if there is any role of memantine. Especially, we use memantine in the hippocampal avoidance upfront to prevent brain necrosis. But do you have any comment on using memantine after brain necrosis?
We don't. I mean, we actually don't really use hippocampal avoidance and memantine for the whole brain, which I think is what you're talking about with the hippocampal avoidance. Just to be clear, but in terms of brain radionecrosis, I agree. It's a really difficult problem, and it's something that we really fear in our patients, and obviously we consent everyone for it. When we see it, we will look at the extent of the first thing is the patient symptomatic, because that will completely determine whether we intervene or not. We see some cases where you see some changes on the post radiosurgery MRI, and you just sit tight, hold your breath, and they settle. And you think, phew. And even with edema, depending on where it is in the brain, the patient might be completely asymptomatic. If they've got symptoms, we will try steroids in the first instance, but we will also monitor the patient quite closely and see how they get on, A, in terms of the radionecrosis symptoms, B, in terms of their steroid side effects. And we will discuss, we'll review the imaging, and if they're getting better, then they may not need anything. But the other thing we'll bear in mind is whether surgery can help to reduce the symptoms, because that one of the patients I showed whose tumours blew up post Gamma Knife, who's coming for the trial, she ended up being symptomatic first from the right frontal one and then from the left-sided one. And each time she had a resection, and she felt much better after that, came off the steroids, went back on the trial, and then the other one blew up, had surgery again. It was all radionecrosis, and she went back on the trial. So if there's a surgical option, meaning if it's in a non-eloquent part of the brain, then we would look for surgery if it's symptomatic and not settling quickly on steroids. The other thing we would prefer, rather than we would choose, would be bevacizumab, so Avastin. And there is data from a very limited study by Levin et al., which showed a significant improvement with bevacizumab in patients with radionecrosis from a number of things. Yep. And actually, we can sometimes access that here. It's not routinely allowed, but we would try and, in order to get people off steroids, if they're having a torrid time on the steroids, we would opt for Avastin, and we've seen some very good responses, and it's an excellent steroid-sparing agent, so we would go for that.
Thank you.
Okay, thanks a lot. Now we'll move to the second talk. I have the pleasure and honor to present my dear friend and my big brother, Dr. Khalid Abdelkarim, one of the eminent oncologists in Egypt, and he has a long experience in treating patients with brain metastases and SRS. Please, Dr. Khalid.
First, thank you so much, my dear friend, Dr. Wael. Thanks to the Bahia Foundation for continuum of the 5th year of this international conference. Thanks to the organizing committee and my friend, Dr. Ahmed Amin. After what Dr. Rosenfeld has said, I have a little bit to add with the Gamma Knife, except to describe what is the difference actually between the Gamma Knife stereotactic radiosurgery and the stereotactic radiosurgery with the LINAC. So we have our Gamma Knife center at Nasser Institute. I'm a consultant right there. I hope it goes easily. I'll go very fast with the data that have been already described by Dr. Nicola. So take you back, because I will add a little bit of information to the basics. This is, we have learned some 30 years ago about the 4 Rs. Now we are believing that are 5 Rs, and the new research goes for the 6 R. We know that radiosensitivity is very important issue to tackle when we are dealing with stereotactic radiosurgery, and in the past few years with the emergence of immuno-oncology, we are dealing also with reactivation of immune response. And to remind you, dear friends, with the difference between the conventional radiotherapy, the stereotactic radiotherapy, and stereotactic radiosurgery, this collects the data. What is the size difference, the dose difference, and the fractionation? Very fast, because Dr. Nicola said a lot of very important things about the emergence of stereotactic radiosurgery over the whole brain radiotherapy. But to remind you, everywhere, whole brain radiotherapy, even after using the hippocampal sparing, as Dr. Marwan said from Canada, it still comes with the price. So a little bit of the neurocognitive functions. This paper was 15 years ago. It was about to be the only pilot study, but this time in 2007, and 2/3 of the brain metastasis patient had impaired neurocognitive function at baseline. The majority of 5 long-term survivors had stable or improved neurocognitive function. Actually, this was the first time ever we are dealing with improved neurocognitive function after stereotactic radiosurgery. What are the facilities? Dr. Nicola have shown us the LINAC, the different beams from the LINAC from multiple arcs or half beam arcs, and the cyber knife with the robotic arm also. And we are pleased that we are at last having an operating CyberKnife in Cairo right now. Gamma knife was discussed for metastatic lesions as early as 12 years from now. The first published larger data about using gamma knife radiosurgery. We published some very small trial from our center some 10 years ago in 2011 in an international conference in Cairo to see about the overall survival, the disease-free survival, and the number of lesions treated. We concluded by this abstract that gamma knife radiosurgery could serve as an effective primary or salvage treatment of brain metastases of breast origin with a high rate of disease control, favorable toxicity profile, and preserved or improved performance. This is our team. We are having 3 neurosurgeons and 2 radiation oncologists. I'm originally a clinical oncologist, but I'm dealing with myself in this team as a radiation oncologist. So I agree with Professor Rosenfelder that we are having a daily MDT that goes 5 days a week. We discuss the cases all together. With the images, we can ask for further investigations in a day or 2. Then the decision comes in the first MDT clinic in 1 week, like the chart she was dealing with us a few minutes ago. Then the treatment of brain metastases is having the first priority actually at our center. So again, we agree about the 2 weeks from the time the patient comes to our center till the moment of the treatment. But the time in between is very much condensed into the day of treatment because we are not having the MRI pre-treatment, we are not having registration in the days before. Everything goes at the same time. This is how gamma knife is focusing 198 cobalt sources beams into 3 different collimator sizes into the center, which is the isocenter of a single shot. So what is the difference again between the gamma knife and the stereotactic radiosurgery by LINAC? First, we are having the frame. So we are very much having a knowledge that the patient is not moving. We are doing measuring the coordinates, which is a crucial step in our treatment after having the MRI. We are importing the images and check every image on the gamma plan. We are having a very accurate images, 1 millimeter thickness, and the fiducials around the MRI image shows us the 3-dimensional thing of the gamma knife planning. Then we can add our shots right there after co-registering all the images. The shots can treat a lot of cases, a lot of lesions. And when Professor Nicola have make a reference to Dr. Yamamoto, I remember meeting him some 8 years ago in New York. He was bragging that he's the crazy neurosurgeon who can treat 70 lesions by gamma knife. He was using gamma knife overnight, which is a nightmare for any neuro-oncologist around the world. So when the questions we heard a few minutes ago about the 12 gray isocenter or the 12 gray volume of the brain that received 12 gray, I was very much pleased to give the difference. Actually, we are treating between 18 and 20 grays for a single fraction, and the very fast fall off from the area treated or the target volume allows us to accurately calculate how much of the brain that receives 12 gray, and this is very, very much smaller and by far fraction of what LINAC can give. Yes, all machines are coming together right now because we are having the gamma knife with cone beam CT, and I'll discuss it very shortly. But definitely, because we are not using many half beam arcs or thousands of beamlets, then we are having very sharp fall-off that the brain is not so much affected, and we are not that afraid of brain necrosis. And we can do our DVH for each target. We treated at our center regularly between 5 to 10 lesions. This is maybe our daily practice. Definitely the easiest is the oligometastasis, or fewer than 5. But as Dr. Nicola said, it depends about the size of each lesion, how proximal all of them to each other, because we can't treat it at one session 10 in different parts of the brain, because this will be very much longer time. The treatment is usually less than 1 hour, 30 minutes to 45 minutes, give or take. So we can treat multiple lesions. If you are dealing with fractionation, it's fractionation 1 for the volume. If the volume is larger, I can treat today half of it, and after a few days, the second half of the volume. Again, we can fractionate the dose, and we tried it, and it was very elegant, especially if the lesion is near to a very eloquent area of the brain, like the brainstem. So we give like 14 or 16 gray at a session, and the other session in 2 weeks or so, we can give another 12 or 14 grays. But usually, for a standard tumor like this one, we can use 18 to 20 grays in a single fraction. So this is one of our patients. She was a 48 years old lady, treated. She was originally discovered with this lesion because we had a question from the floor about treating upfront. The treatment of gamma knife is a single day. It won't stop or prevent you from giving your systemic treatment. So the patient was discovered, treated, and during the 4 months of the systemic treatment, we have found that the tumor is nearly disappeared. And the edema with using steroids improved, and definitely we had much better effect on the epileptic fits that the patient had by the time of presentation. Another sequence of a lucky patient. She was alive for more than 2 years, and we have been following this small lesion, and it almost disappeared, and she was lucky. She was from the earliest patient who received Herceptin in Egypt, so she completed her treatment, the systemic treatment well, and the general condition allowed us to keep following her till more than 2 years from treatment. This to prove my talk about the staged, if the tumor is more than 2 cc, the single tumor more than 2 cc, we had always for the gamma knife the legend or the urban myth of the 3 centimeter, so and so. No, we can do staged treatment, and we can do repeat stereotactic treatment, and it's more safe definitely than having whole brain radiotherapy pre or post stereotactic radiosurgery. If you are treating the lesion and you found that the lesion is growing after 6 months, 1 year maybe, and we are doing our best with our available radiation diagnostic machines, with the with the help of MR spectroscopy, and using the amino acid PET MRI, which is available in Egypt, and I recommend some of you can use it to see how the lesion is after few months, and what is the radionecrosis thing, and what is the progression, and what is the new lesion appearing at the borders of the tumor, as we have seen earlier. Those have been discussed earlier with Dr. Nicola, and I'm just putting this to say that definitely for the younger age, below 50 years, stereotactic radiosurgery favored survival. This was the first time for this publication to see a favorable survival in a specific age group. Again, what about the 4 and more metastases with gamma knife? It is not there anymore as an obstacle. And what about the factors influencing the outcome of stereotactic radiosurgery in patients with 5 or more? This paper that was published in 2019, that they suggested that the collective size of whole volumes of the metastasis is no more than 6 cc. Definitely in our daily practice, this is not taken in consideration. 6 cc. I agree with Dr. Nicola about the 20 cc, and sometimes if we are having many lesions, we can go even above the 20 cc sometimes. Can we use it alone without surgery? This paper was published in The Lancet in March 2015, and in the past and sometimes even today, whole brain, it's not today, it's 7 years ago, whole brain radiotherapy was used indiscriminately for all patients with brain metastasis, but current class 1 evidence has shown that whole brain radiotherapy on its own does not durably control brain metastasis and can compromise survival in some patients when given without surgery or SRS. This is the latest NCCN guidelines published 1 month ago, and for our friend Dr. Marwan from Canada, when he said that whole brain radiotherapy with hippocampal avoidance, yes, it is there in NCCN guidelines, but if I can avoid the whole cranial and avoid the tedious work for hippocampal avoidance, and I'm having the facility to treat more patients with the dedicated LINAC that can have the facilities of SRS, meaning the triple F and all, I would go for the second option with SRS in selected patients. And for the newly diagnosed or stable systemic disease, you can see right there in the second row, it's also SRS as preferred treatment. This, you can see the second row right there. And for the recurrence, and this is the good news, because some 2 years ago, this page was not like this in the NCCN guidelines. For recurrence, for the patients who had previous surgery only, there is SRS, the first line for the surgical bed. For the previous whole brain radiotherapy, surgery followed by SRS. For the limited brain metastasis, surgery followed by SRS. The only thing that is recommended for whole brain radiotherapy with hippocampal avoidance is extensive brain metastasis. Extensive, in my words, is more than 15, dispersed all over the brain, and many of them are of larger size. At Gamma Knife Center Nasser Institute, we treated only about 200 patients with brain metastasis in 20 years. Why? Because we are not endorsed by the government to treat them. So many of our dear radiation oncologists still thinks that it is cheaper, more available to go for whole brain radiotherapy for those patients, and this is criminal act. Please don't. If the patient is controlled systemically, if the patient is younger, if the patient have a life to have with good quality, go for stereotactic radiosurgery. I'm not biased in this moment for the Gamma Knife, but with any facility that can provide stereotactic radiosurgery, even LINAC or CyberKnife. We treated 94 patients of breast origin from our metastatic group with local control of more than 95% in the first 6 months. I didn't tell a word about overall survival or disease-free survival because we are mostly related to the tumor control, because this will keep the patient in good shape for the months or the years she is surviving. So what about the new machine, the icon we are having? This is the bridge between the LINAC and the Gamma Knife. We can do frameless stereotactic radiosurgery with the Gamma Knife with cone beam CT. So if the patient comes with like 20, 25 lesions, I can do it in 2 days. Each day I'm having 7 or 10 lesions. And I'm not in a position to put a frame with all of the problems of the frame. It's only having the mask-based treatment. And so the machines are coming together to the same terms after many years. Stereotactic radiosurgery and immune oncology, is it the future? Many ongoing trials. This paper have been published in Neuro-Oncology Advances less than a year ago, and all of these are ongoing trials right now, and about half of them are dealing with stereotactic radiosurgery with some kind of immune oncology. Remember, I told you earlier in my presentation that the modification of the immune response by the stereotactic radiosurgery can change how we are looking to the disease. So please remember, whole brain radiotherapy is not preventing further brain metastasis and is not improving quality of life. And stereotactic radiosurgery is treating larger lesions than the past. Stereotactic radiosurgery is not anymore for oligometastasis, can be used at time of recurrence, and whole brain radiotherapy is not improving survival over the stereotactic radiosurgery. So before thinking stereotactic radiosurgery, MDT with proper evaluation, control of primary is a crucial. Estimated life expectancy, as I told you, 6 months is the thing, as Dr. Nicola said also. Extracranial metastasis is important to discuss with the role of PET-CT and PET-MRI. Prognosis still poor because the brain metastasis comes for poor prognostic patient. Treatment intent is palliative, and this might change in the future with the use of immune oncology system that allows for tracking, gating, and high-dose delivery. Gamma Knife, Cyber Knife, LINAC with the F capabilities allows us to deliver treatment in very few number of fractions. So radiosurgery is an option to be offered for patients with expected survival more than 6 months, where cognitive functions preservation is important, especially if under 50 years old. At time of recurrence, Gamma Knife radiosurgery can be re-employed. I hope I didn't bother you. I'm late for 30 seconds or so, and thank you so much.
Thank you so much, Dr. Khalid. Such a perfect presentation, and thank you for sharing long years of experience. It's really was a great pleasure to have such advanced treatment in our country. It's an honor for us actually to have it. Is there any question for Dr. Khalid? Please.
Thanks, Dr. Khalid, for your elegant presentation. The decision of re-irradiation is a very difficult decision for any oncologist.
Definitely.
Either the second or the third re-irradiation. So I want to know your experience according to the period of time, duration between the first radiotherapy and the second radiotherapy,
yes,
and also the third radiotherapy. And is there any difference between LINAC and re-irradiation with Gamma Knife?
Let us put it in terms. First, if you are dealing with metastasis, I will use the words of my dearest mentor, Professor Lundquist, who said, "Let us burn the damn devil." You are not afraid about the brain. You are having a very sharp fall off with a very good Bragg peak effect. Then you can treat it easily. But definitely for the radionecrosis and the edema comes afterwards, 6 months is the least acceptable time before having the second treatment. I'm not a believer of a third treatment, actually. We did it when we have a tumor of metastasis, let me put it this way, that comes away from the field that was irradiated, not the same lesion, the same isocenter. Because if the same lesion, the same isocenter have received, in my own humble experience, the third radiosurgery, the radionecrosis is massive, the edema is massive, and what I was aiming for, preserving function, I will lose in this cascade of events. I would go for surgery maybe, and depend on depend on the systemic treatment. If we are dealing with the second and third, and we are putting in mind the glioma, it's a different story altogether. Because dealing with glioma with the usual fractionation or the hypofractionation, with the larger lesion, with the linac and not with the gamma knife, because gamma knife is not meant for the high-grade glioma, I believe it's between 6 months up to 1 year, maybe longer time, because the dose distribution in a glioma is far different. And please, if the lesion is not very small, that can go with a very strict dose constraints to the tumor and the risk areas around, don't go for third radiotherapy, because it's so much drastic and so much bad effect on the quality of life for a patient that is having a shorter lifespan actually in high-grade glioma.
Okay, we're having a last question from Marwan. He wants to add some comment after your elegant presentation. Marwan, with us?
I'd like to thank Dr. Amin, as my friend, for giving me this chance to chat with the shining stars of SRS, either outside Egypt or inside Egypt. And thank you, Dr. Khalid, for this. I'm very happy that you presented your excellent work in Egypt, and I'm very happy that the paradigm of practice is changing in Egypt thanks to you. So, Dr. Khalid, when I mentioned the whole brain radiotherapy with hippocampal avoidance, I didn't mean that we compare it to SRS. We never do.
No. I was not criticizing your treatment. I'm sorry. We are having a very good work that goes with hippocampal sparing in the Cairo University and in the National Cancer Institute. I mean, when you are playing, play nicely with your toy, play to the best of your experience. That I was
exactly.
I was meaning. I was not meaning it's not working well.
You know, because there might be some junior residents that might think that we compare SRS to hippocampal sparing.
Understood.
No, we use SRS. Usually, we have our eligibility criteria. If the patient is not meeting these eligibility criteria, we never use whole brain. We use hippocampal avoidance in every patient is eligible for whole brain.
Yes. This is
I mentioned this because I wanted to discuss the Memantin rule and
perfect. As I showed, I was just proving your point of view. When I put the NCCN guidelines, it comes when you are giving hippocampal avoidance whole brain radiotherapy, give Memantin. And Memantin have some memory for me. Memantin, for the people who are not knowing what is Memantin, Memantin is Aricept. I use it for my late father who had Alzheimer. It was originally treatment for Alzheimer, and it was found in early 2000s that it can help those who receives whole brain radiotherapy to recover their cognitive functions well. So if we are having in the MDT a case that is having massive, as I told you, I used the expression wisely, massive metastases, and they will go for whole cranial, do the whole cranial radiotherapy with the hippocampal avoidance, with careful usage of steroids, and if possibly with Memantin. You are totally right. Thank you so much.
Thank you.
Thank you very much, Dr. Khalid. Thank you again for the presentation. And now for the last session in our workshop. It's supposed to be a practical session. We're going to talk in some practical terms after reviewing all the data on the brain metastasis SRS. So again, we're going to go back to Dr. Nicola, and it's a great pleasure for us that Dr. Nicola had the opportunity to invite two of her colleagues Martin Brewer, a specialized radiographer at the Royal Marsden. Actually, I've heard a lot about your work, Martin, actually from Dr. Heba, so I know you're one of the best, actually. And Carol, I hope she already joined us. Carol Mihan, clinical medical physicist. So I just want to welcome them for joining us, and the floor is yours to share the clinical experience.
Okay, so sorry, thank you very much, and yeah, thank you for the excellent presentation. We'd like to just, we're going to present 4 cases in total, each one hopefully demonstrating different aspects of our of practice. And they're patients with different sort of types of breast cancer, hopefully each one with a different message. So the first patient is a 78-year-old who originally had surgery for a triple negative breast cancer. It was a 27 millimeter grade 3 invasive ductal carcinoma. 0 out of 1 lymph node was involved. She was advised against adjuvant chemotherapy because of comorbidities with type 2 diabetes, hypercholesterolemia, hypertension, etc. She had adjuvant radiotherapy, but unfortunately in November 2021, so nearly 3 years later, she developed metastatic disease in the lymph nodes, lung, and bone. So she started capecitabine and denosumab, but developed some dizziness and was found to have and had an MRI scan, and was found to have 4 metastases, and so had first radiosurgery in February 2022. And I think Carol and Martin are going to show you the radiosurgery plans for her and talk through them.
Am I muted?
No, we can hear you.
Oh, good, jolly good. I hope you can see the screen here. What I'm showing you first of all is kind of where all the METs were. So this is kind of what we would call micro METs. None of them are particularly large. None of them, I don't think, were over 1 cc or 0.15 cc. The red ones are ones which we treated first of all, and the blue ones are the new treatment which we then treated in October this year. So you can see they are spread around the whole brain. Just for showing how CyberKnife treats, obviously treats with lots of different beams, and there's a number of beams which were being treated to the new MET. And so the way that the CyberKnife works, we can avoid the previously treated MET and focus on the new ones. So as you can see from this window here, we've got most of the METs here. We're getting 20 gray, and we were treating 20 gray in 1 fraction. The normal brain for the 12 cc was well below. And in the other window here, we can see the METs treated in the June 2022. The maximum dose was very low.
So, sorry, can I just interrupt very quickly?
Yep.
So this patient had 3 lots of SRS. So like I say, she had triple negative breast cancer. The first treatment was delivered in February 2022, and on her 3-month post treatment scan in April, she had a very good response. But unfortunately, by June, she had 8 new sites of disease. So originally, she had 4 sites treated, then a further 8 in June, and by September, she had 12 new sites and 1 area that had recurred since the original treatment in back earlier in February 2022. So over the course of this year, she's had 3 lots of SRS, and overall we've treated more than 20 metastases. But as Carol's showing you, the dose fall off is extremely fast. That the cyan colour is 10 gray, and the purple colour around the METs is 12 gray. And the tumours themselves have received anywhere between 20 and 21 gray. So the volume of brain receiving 10 or 12 gray is very small, and you can see that the purple and blue isodoses are very, very close to each other. So indicating just how quickly the dose falls off around each site. And because of that, our V10 and V12 was very, very low and well within our constraints. So, yeah, what Carol's showing there is a normal brain. That's a cumulative amount of, but from this particular treatment, the volume of brain receiving 10 gray was less than 5 cc. So that's well within what we would find acceptable.
And as you can see, so this time we treated 13 mets, and the total time was 128 minutes. So it's a long treatment for the patient to stay on the bed, but the patient can come off the bed if they're feeling that they need to, and the setup of the CyberKnife machine is such that the plan is still extremely robust. I don't know if Martin's got anything to say from the patient perspective.
No, they tolerate long treatments very well. They are given regular breaks as needed, and certainly if they need to, they can wave a hand. The radiographers can go in any time, check the patient's okay, even if it is just to visit the toilet facilities or have a drink or something. Yeah, there's no issue at all, and then we can resume where we've left off.
Would you like to go into the next case, Nicola?
Yeah, I'm very happy to. So the next one is a 62-year-old patient, and she's the patient. So sorry, that first case was really just to show how we can achieve very nice, very conformal isodose prescriptions and with rapid dose fall off. As that is quite a straightforward case who's had a couple of further treatments, and hopefully show it can be quite straightforward. The majority of cases are quite straightforward like that. This next patient was the one that I showed in my slides, with the presenting with 5 lesions, with the largest in the right temporal lobe, and she was treated with fractionated radiosurgery. And Carol can talk you through her treatment now. Thanks.
So this treatment here, as Nicola said, we had 5 lesions to treat. As Nicola said, the one here, what we've called the GTV2, was quite large, whereas the others were much smaller. So to be able to get the 12 in for the one fraction, at the moment, this is, if we'd included the GTV2, the larger lesion, the normal brain was actually outside of that. So just this is it showing what the normal brain B12 is just for that lesion here, the GTV2. So obviously that was not acceptable for us. So therefore we decided to do this in 2 plans. The first plan, this one here, was treated just the 4 lesions together without the larger lesion. So therefore, for the one fraction, we could get in 24 gray to the GTV1, 20 gray to the others, and still our V12 was acceptable, and V10 here was also acceptable. If we go back to this plan here for the second lesion, so as I said, in one fraction for the 12 gray, we were never going to be able to meet the constraints which we needed. So therefore, we decided to replan it and do 3 fractions. And for 3 fractions, the limiting factor for the normal brain we use is B19.5. And you can see for that now, it's come well within.
Thanks, Carol. So like we're saying, we look at the global V12 or V19.5 for fractionated treatments, but also we want to look at the local normal brain and what that's receiving. And here we can see that the local V19.5 is less than 5 cc. So for a first treatment, we're very comfortable with that. And I think it's, as hopefully you saw in the presentation earlier, she had an excellent response at that site and also at the other sites, which we could treat as a single fraction. And we are using, in fact, more and more we're using a combination of single fraction and multi-fractionated radiosurgery treatments within a single treatment for a patient. So sometimes if they have, say, a 3-fraction plan and a 1-fraction plan, they may have one longer day on treatment where they have the single fraction as well as the fractionated one. But we found that it works well for patients and allows us to treat a combination of bigger and smaller lesions and tailor the dose to each lesion individually. Other organs at risk that we are concerned about, so we contour the optic nerves, the brainstem, and the cochleas, and we add a margin around them to create a PRV to make sure that we're sort of more cautious about making sure the doses are within tolerance. I don't know if anyone wants to ask any questions about those 2 cases before we've got another 2 to present as well, but does anyone have any questions about those ones?
Actually, we can proceed. Actually, the cases are clear.
Okay. So the third case that we've prepared is a patient. She's only 41 now, and when she originally presented was 2 years ago. She's 39 at the time, and she has metastatic HER2 positive breast cancer. And she presented with a seizure-like episode, and her MRI showed multiple intracerebral metastases with the largest volume of disease in the posterior fossa. Now, there are a lot of advantages to CyberKnife, for example, the fact that we do the planning before so we can carefully design the treatment. It doesn't all have to be done on one day, the fact that we can treat people in a mask, all those sorts of things. But one of the disadvantages of CyberKnife, I'd say, compared to Gamma Knife, is that we can't really send in beams under couch. We can't treat through the couch. And so when we've got disease in the posterior fossa, we can certainly treat it mostly, but the dosimetry isn't necessarily as good as it would be for supratentorial lesions. And so sometimes if we are concerned that the number of METs and the distribution of METs in the posterior fossa is not favorable for CyberKnife, we do sometimes take a combined approach. We would give wider field radiotherapy to the post fossa with posterior fossa radiotherapy, but treat the supratentorial metastases with radiosurgery, and thereby hopefully avoid a lot of the neurotoxicity of whole brain radiotherapy, but it allows us to get control in the posterior fossa and supratentorially, and we know that we could come back and boost the posterior fossa if appropriate down the line. So this patient presented with many, I think it's about 25 metastases in June 2020, and I elected to give her posterior fossa radiotherapy with 20 and 5 and SRS to 21 supratentorial metastases. So I actually contoured the posterior fossa disease as well at the time, which are the white contours. But she underwent treatment and did very well, actually, and remained on pertuzumab and trastuzumab. And she had a very good response, both in the post-fossa and supratentorially. That was June 2020. In March 2021, there were some things sort of beginning to look like they were re-emerging. 3 in the cerebellum, which hadn't had radiosurgery, and 6 supratentorially. So we treated her with further radiosurgery. And Carol, I don't know if you want to talk through how we delivered that.
So again, this was another plan which we decided to do in both 3 fractions and 1 fraction, purely because we were not going to get everything in 1 fraction, but some of the METs here, as you can see, were tiny, so therefore they would also benefit from the 1 fraction. So our GTB 1 and 2, which, as Nicola was saying, were retreats as well, were more sizable, so they're the ones we did in 3 fractions, and the rest 3 to 9 we did in 1 fraction. So as Nicola said, the dose distribution here, you can see, because we're coming all around, we can't really come under couch as much. Sometimes it's not quite as conformal as we'd like, but it's still, I would say, pretty good conformally around the tumour. the orange line here is the prescription isodose. And so even though we can't come under couch with CyberKnife, we can still get a very conformal dose distribution around it.
Tara, while you're on that slide, if I could just say that the white contour was the disease she had originally before the post-phospho-radiotherapy, and the orange contour is the the orange colour wash is the target for when we did the retreatment. So the white contour received the posterior phospho-radiotherapy, the wider field radiotherapy, and then this was the boost dose really to the residuum.
And the way that we ensure that our 1 fraction and 3 fraction plans are giving us the dosimetry which we're showing the clinician. We have got a process in the precision planning system where you can sum the plans together. So we will sum the plans together. So this one down here is the 3 fraction plan, showing the dose of the 1 fraction plan on it, and likewise this is the 1 fraction plan up in the top window showing the dose on it, and therefore we could actually look to see what the doses are being received for the 3 fraction and 1 fraction plan, to ensure that on the 1 day of treatment where the patient is being treated for both plans at the same time, then the 1 fraction plan is not going to be getting more dose than we think it is, and likewise the 3 fraction volumes aren't. So there's obviously some slight differences between the actual doses from the single plans, because there is going to be some overlap, but we ensure that they are within our standard limits. The normal brain we actually just take from the 2 separate plans, because obviously with the different fractionation you can't really sum the normal black brain together.
Yes, we look at the volume of the V19.5 on the fractionated plan and the V12 on the single fraction plan. And if they're both somewhere close to 10, then we may reduce the dose either on the single fraction or on the fractionated one. But as you can see here, the normal brain on this fractionated one was very, very low. And then we might look at the normal brain on the single fraction. And again, if it's, if it's low, then we won't worry about it being too high. I know there've been a few questions about giving a second radiation. We don't take into account we don't look back and see what volume of normal brain was irradiated with previous treatments. We start from scratch each time, and that seems to be absolutely fine in our experience. A couple of interesting things about this patient is that since this re-irradiation, she had a very good response, but then things started to re-emerge. She was actually, for the sort of clinical oncologist in the audience, she was given Kadcyla, but unfortunately her ALT went up to over 1,000, so that was stopped immediately, recovered fully. But she was then started on trastuzumab and tucatinib, and she seemed to have some intracranial response to that as well. But over the last year or so, some of the lesions look like they may be re-emerging. For example, in the right frontal, that one that was irradiated a couple of times, and the one that Carol's just scrolling through now. But they've waxed and waned, actually, and I've sort of sat tight and just watched them. And at one point in September, it looked like they were progressing, and talked about further radiosurgery. And actually, when she came up for her planning scan, they had waned again. So just again, in tumours that have been irradiated once or twice, I think sometimes just sitting for a bit and watching them can be very helpful and quite important. And again, with her, we did this tram scan, CCA scan, which sort of helped us. So she's doing well at the moment, and she remains now just on systemic therapy on Kadcyla. Our fourth and final patient is 55. Well, she was 55 when she originally presented. She's now 57. 5-year-old patient with triple negative breast cancer. She originally presented in May 2019. She had invasive ductal carcinoma, as I say, triple negative of the left breast. And she presented, she had first SRS in June 2019, where we treated one lesion in the left cerebellum. She then had systemic treatment and did very well. But we gave further radiosurgery 9 months later in March 2020, where we treated 3 new lesions. All of the treatments were 21 gray in a single fraction. But by July 2022, which is just over 3 years after her initial disease, which is, we think with triple negative breast cancer, we wouldn't expect necessarily a patient with brain metastases at diagnosis of metastatic disease to be alive 3 years later. But this woman was alive, not only alive, but still working full time as a nurse, a pediatric nurse. She looked like she had some further disease re-emerging in the left cerebellum. So we gave her further radiosurgery to that area. And because it was further radiosurgery, we fractionated it. And Carol, I don't know if you wanted to show that one. That was the third SRS treatment.
Yep, so I think Martin's just showing the trams and kind of where we actually knew we had to treat.
Yeah, sorry. I think it's sharing a particular screen, and it's another one that we've got up. So if you bear with us.
That's so just while Martin's bringing it up, this is the CCA or tram scan that I've talked about before, and that is really where we take a delayed post-contrast image at 60 minutes post-contrast and subtract the 5-minute one from it to see how much contrast is still hanging around. And this is very much, we use it mostly in patients where we're not sure if it's radiation necrosis or progressive disease.
I think that was fine. It was because it was all in the planning system. Yeah, so this is the tram scan on the right-hand side of the screen, if you can see that. Yes, this is the cerebellar lesion, and on the left is the structural imaging. So checking I've got the right ones. This is the latest MRI from July, and then this tram scan is from last year. So on the structural imaging, you can see the enhancement within the cerebellum there. As mentioned, there were some other lesions which were treated. So there's one here on the right. Where were the other ones? I can't remember where the other ones were.
So it's right temporal and right parietal. I think it's...
Okay, probably very small.
Yeah.
Anyway, that was the main thing. There was also this Fermion lesion here. But on the tram scan on the right hand side, so like I said, this is this slightly older scan. And as Nicola mentioned before, the the difference in contrast is shown by the colours. So if there's rapid contrast clearance, that will show up in blue. And delayed contrast clearance tends to be in red. So yeah, as was mentioned earlier, so it tends to show that if there's good clearance, that tends to be a viable tumour because it's got good blood supply, whereas reaction, because the blood supply isn't so good, there's lots of damage, then that would show up as red as the contrast hangs about. So yeah, I think the main issue for this patient was the appearances of this on the scans. And you can see there's quite a lot of blue there. There is some red there as well from previous treatment on that particular lesion. Yeah, there's another lesion up here. It won't show up on this particular scan because that was treated and now that's just a tiny remnant. Yeah, and then that cerebellar, that Fermion lesion that's shown as blue, that was untreated, possibly at the time. Is that showing up as new?
So we can go to the treatment plan now.
Right, where is...
Probably need to stop sharing.
Yeah, I need to go to the middle of the screen.
So this was in 2021,
On here.
and she'd already had radiosurgery to that once at that point, and that initial early radiosurgery was 2 years earlier in 2019. So we used the tram to delineate, because there was, as Martin showed, there was a mixture of the red radiation necrosis or radiation related change, plus the blue, which is the areas of tumour recurrence. We used the tram to identify which areas we wanted to treat with further radiosurgery. And as Carol's showing, we were able to deliver fractionated treatment to that with further, I think it was 24 grey and 3 fractions.
So yeah, so this one here, we've got the 21 grey, which was the previously treated, the one which we were showing with the trams. It's now slowing up, I'm afraid, my computer. The lesion here, we treated with 21 grey. And this one again with, which one's that one?
I think
that's 24 grey, sorry. This one's 24 grey. So you can see we managed to get a lovely dose distribution in for all 3 of them with the help of the imaging.
And this patient then went on, she was again extremely well, remained extremely well, and has been on capecitabine and living a full life. But unfortunately, once again, she had a further site of possible recurrence of, again, worrying for recurrence in the left cerebellar tumour. And because the overlap isn't entirely with the previously treated areas, we were again able to use another tram scan to deliver a third treatment. So whilst we are very, very hesitant to do it, and we hardly ever do it, there has been the occasional patient who is very well and has basically a solitary site of disease recurrence, where we will do it if enough time has passed since the previous irradiation. But I agree that we would have to do it very, very cautiously, and really, if it is in a very eloquent part of the brain, we may not want to do it at all. But this patient has had now 3 irradiations, 2 bits of that area, and has got excellent tumour control. I've just seen her in clinic actually last week, and her scan is absolutely stable and fine. So for a patient, like I say, with triple negative breast cancer, who first developed brain metastases in June 2019, I think that's that's a very good outcome.
I think that's all we've got to present here. I don't know anything else which people would like me to try to show on any of the scans. I hope the screen sharing did actually work in the end.
Yeah, I think so. Is there anything anyone wants to ask about any of those cases?
No, actually, thank you so much. They are really interesting cases. I believe we have just a few questions. We're going to allow them before the end of this workshop. So I believe, Dr. Sarah, you collected the question. Can we proceed with the questions?
Yes, thank you. For the CT simulation, do you do it with contrast or without? This is the first question.
Mm-hmm. Without. We use contrast for the MRI, but yeah, the CT is without contrast.
Are there? Okay, thank you. Are there any specifications for the thermoplastic mask, like special thickness or special a hard thickness one, or just the regular one?
So Martin's done a lot of work with this. Martin, do you want to answer?
Yeah, no, it was just a standard, well, for us anyway, standard radiotherapy thermoplastic mask, 3-point shell. I believe the thickness is 3 millimeters. And it's the same mask that we use for all of our brain patients and also for the head and neck patients where they've got a 5-point shell. Same manufacturer. We have also been looking into some open face masks which have some additional reinforcement around the face and around the ears. And yeah, so far our work with them suggests that they are a good alternative, particularly patients that are struggling with claustrophobia. But yeah, we don't use anything special for our radiosurgery patients.
We've previously done work in the sort of old days. We used to use a Gill Thomas Cosman frame where patients would have a mouth bite and then that would be fixed to a frame which was fixed to the couch. That required a dental appointment. The mouth bite was very uncomfortable for a lot of patients, and it was not a very nice way of fixing people. And we did work to show that with adequate or good imaging on the treatment machine, frequent imaging intrafractionally, we can get the same setup. We can use the same. In fact, we reduce the margins on the basis of the accuracy that could be achieved with a frame rather than the Gill Thomas Cosman. With the thermoplastic mask rather than the Gill Thomas Cosman frame.
Yeah, and certainly on our CyberKnife unit, we do take regular stereoscopic X-ray images of the head throughout the treatment, maybe every sort of 30 to 90 seconds. And if there is any discrepancy between the position of the patient at the time and what was planned, then certainly the radiographers can intervene. But the CyberKnife system does have quite clever things behind the scenes in place where it can make them corrections as it's doing the treatment. So we always know that the treatment is accurate, regardless. So yeah, like I said, we don't need to do anything extra for these patients because we know that the accuracy will always be sub-millimeter and like very fine in terms of rotation as well.
Actually, I have a question to Professor Carol regarding the plan, because I'm doing an Linux-based SRS in my hospital. So regarding the plan, did you think that doing a non-coplanar plan could be allowed, or you always go for the non-coplanar plans, even for the simplest plan like small 1 lesion? And the other thing, are you using just the number of arcs? Do you have any recommendations for the number of arcs if we're doing some SRS with the VMAT technique?
We do actually have a VMAT technique on our LINAC as well, following using a software called Elements from BrainLab, and that we use 5 arcs generally. Again, though, we generally treat ideally up to about 5 METs at the time. If it was just a single MET, the CyberKnife treatment treats it extremely quickly. But no, also, I mean, a single MET on a LINAC with a planar VMAT plan would be perfectly acceptable, yes. We're very fortunate that we have a choice of delivery systems here. But certainly the CyberKnife with the micromet is certainly ideal because of the small collimator sizes we can treat down to. But generally for our VMAT treatments, for our multi-mets on the LINAC, we will use 5 arcs.
Even a non-coplanar?
5 non-coplanar arcs.
Non-coplanar, but coplanar, you don't prefer coplanar plans even as a single simple plan?
As a single simple plan with 1 MET, a planar VMAT plan would be perfectly acceptable, yes.
Okay, great. So,
there's a second question. The slice thickness of the CT is 2 millimeters, or do you prefer a smaller thickness?
We do 1 millimeter.
Okay, so 1 millimeter for the MRI and the CT.
Yes.
Okay. Do you have a problem with the fusion? Do you sometimes face problems with the MRI and CT fusion? And how do you overcome that?
Occasionally, it can never always be perfect. We've had a lot of communication with our MRI colleagues to ensure that they understand what is important for our registration. And so it has improved over the years which we've been doing it. I think that's the most important thing, is to have a good communication between the MRI radiographers and physicists to ensure that they understand what we need for the registration and why it's so important. Our patients for the MRI planning scan are scanned exactly as they would be for the CT scan, and generally within the same day, I think.
usually within a few hours of each other.
But yes, occasionally we do have problems. When there are slight issues, then we will talk to the clinician, and the clinician will give us feedback as to whereabouts they want the registration to be done. If the registration is not good for the whole brain, then we will do the registration multiple times, possibly on different parts of the brain, depending on where the most relevant part will be for the clinician to outline correctly.
Okay, thank you. My colleague has another question.
So can I just quickly add, so most of our patients will have had a diagnostic scan within 2 or 3 weeks. So in order, because the pathway is so tight, we standardly have slots just for a post-contrast MRI. So we just have the T1 sequences post-contrast. Occasionally, we do request additional sequences, like, for example, if a lesion is hemorrhagic, we don't want to necessarily treat the whole area, we just want to treat the nodule, not the whole area of the hemorrhage, then we might ask for pre and post-contrast sequences. That's usually more relevant for melanoma rather than breast cancer metastases, but can be. And sometimes lesions are not very visible on the post-contrast and are easily detected on a FLAIR set of sequences, so we may ask for those. But yeah, the CT is without contrast, but the MRI is just the post-contrast imaging.
Dr. Nicola, I want to ask you for the remaining brain tissue and the blank constraints regarding the remaining brain tissue before the second re-irradiation. Are you going to subtract the PTV, and how you calculate the remaining brain tissue? And you have any data correlation between the volume of the remaining brain tissue and the cognitive function for the patient in the second re-irradiation and the third re-irradiation?
So in terms of the, we simply just always just subtract the GTV from the whole brain, and even if that's a second irradiation, we just start from scratch and again use the same dose constraints, but we will be a little bit more cautious. So, for example, like I was saying earlier, we look at the local V10 or V12, and we want it to be less than 5 cc for a primary treatment. When we can, we want it really to be under 2 cc for a re-irradiation, and we'll have a much lower threshold to move to a fractionated treatment. In terms of your second question about cognitive function following a second re-irradiation, because of the complexity in collecting good cognitive data and the need for really good neurocognitive, I think you need specialists actually to collect really robust data. We don't routinely go and look for that even with a second re-irradiation. I can tell you anecdotally in the patients, for example, that last patient we saw, I've not known of anyone who's had really significant neurocognitive decline with a re-irradiation. Having said that, we have had the occasional patient with radionecrosis, but because we refer our patients back to the primary oncology team, they do normally contact us if the patients develop neurological sequelae that we're worried about, that they are worried about. So anecdotally, I can say it's not a big problem. I don't have robust data, but we are at the moment undertaking a study called the SAFER study. The primary endpoint is really looking at seizure activity in patients undergoing brain metastases to see if we can identify what are the true risk factors for seizure development, because in the UK, everyone is banned from driving. Everyone with brain metastasis is banned from driving, whether it's a micromet or an enormous metastasis, and whether or not they've had a seizure. So we're looking to identify what are the true risk factors for that. But one of the secondary endpoints of the study is looking at the local radiation response and looking at the tumor control probability with the different doses that are used, and also looking at the risk of radionecrosis with the different doses and fractionations. Now, a lot of those patients will come back for further treatment in the study, so I think we'll get some really valuable information. And we had quite a lot of discussions about whether we should include neurocognitive outcomes in it, but because the neurologist with whom we work, who actually advises our driving, national driving panel, felt that in order to get really good data, you have to have really dedicated neurocognitive function. So we elected not to do that because it probably hamper the whole study. But like I say, anecdotally, we haven't got a problem, and we will get some data from that study, which is a prospective observational study where patients are reviewed every 3 months. So we will probably know if we'll certainly know if they've had seizures. We may also get some other data, but we won't be formally testing neurocognitive function. And I think one has to be really careful about making assumptions about neurocognitive function, because it has to be so carefully tested and with a validated scoring system.
Okay, the last question.
The last case you showed, she had a lesion in the left cerebellum, which was almost abutting the brainstem. And I saw that those lines of the coverage were touching the brainstem. How did you meet the acceptance criteria for the brainstem in such case?
Yeah, I think we contoured the brainstem, and I think that one was treated. That was it was a cerebellar tonsil lesion, and we treated it initially with 21 gram 1 fraction, and I think it was smaller then. The later one that we showed, I think that was when it had grown a bit, and that was retreated. It was initially treated in March 2020, and then we retreated it later with, and we delivered fractionated radiosurgery. So when we struggled to meet the constraints with single fraction, we often can do it with the fractionated radiosurgery, and if needed, we drop the dose. But I think we managed to get 24 gram 3 fractions the second time to that.
Unfortunately, we have to stick to the time, so it was a great pleasure to have you all. I'd like to thank our honorable speaker, Dr. Khaled Abdelkarim, and our colleagues from the Royal Marsden. It was a great pleasure. Hopefully, next time we're going to meet all together in person here in Cairo. I just want to ask for a last thing, that we might take some photo together for our memory. We're having you here in the screen, so we might just have this last photo, and then we will go to the end of our workshop. Thank you very much.
Thank you very much. Thank you.